So the next thing we're going to talk about with inflammation and when it goes awry is sepsis. Now, sepsis is becoming a more frontline problem. It's starting to be realized that we see a lot of patients that are in sepsis, and sepsis kills a lot of people. In fact, if you were to run the numbers of, you know, all the really cool, sexy calls that you get, like MIs and traumas and strokes, all those things that have quote unquote codes when you call them in, like a STEMI code alert or something like that, you'll end up actually finding that sepsis, not only do we see sepsis more, especially pre-hospital, but sepsis will kill far more patients than MIs, traumas, and strokes. And also the patients that typically come into the hospital with sepsis by ambulance are so sick that they're typically worse off than the ones that, say, have sepsis and walk through the door. So what that means is we're seeing a large amount of these patients that are super, super sick. And maybe some of the places you work or some of the hospitals that you deal with are starting to develop these code sepsis protocols so that you can have early activation of the hospital. Because another thing that's being found out too is that these patients really need antibiotics and fluids and treatments. And if EMS comes in and they say in their handoff report, even without some sort of special early alert, if they say that they suspect sepsis, these patients tend to get treatment faster than if the hospital had to realize that this patient was septic on their own. So very important stuff, very cool stuff. Like this is one of those things that I think we're using our brains and being clinicians and real medicine. This is one of those things. So sepsis, is going to be focused a lot on when the pathogen is bacterial, fungal, and viral, right? So in anaphylaxis, we stated that the person was a susceptible population in that they had a genetic predisposition to overreacting to an allergen. In sepsis, we have susceptible populations as well. Not as much in the genetic sense, although there could be. But what we kind of start out with is we need a good assessment, and a part of our assessment is looking at our patient and if they fit into a certain type of population. So these people that are really susceptible to sepsis are populations like the geriatric, diabetics, people that are immunocompromised, either they have a disease such as HIV/AIDS, possibly cancer, and they're on treatments for that. Other things could be recent hospitalizations, and if they have any kind of medical devices like PICC lines, or PICC tubes, and things like that. Do they have urinary catheters in place? These patients are going to be a lot more susceptible to sepsis. So how does sepsis happen? How do we get from something that is probably most likely controlled, right? We have just like a little bacteria that, our body can probably easily fight, but how does it get to the point where it goes beyond just a local infection to a systemic inflammation, and because that's what sepsis is, it's systemic. So what ends up going to be happening is that these infections somehow get their way into the bloodstream. So similar to anaphylaxis, where the histamine got its way into the bloodstream and then created a systemic problem versus a local problem, in sepsis, somehow our pathogen, our infection is going to migrate into the bloodstream. And a great example of this, one that we typically see a lot, is a UTI. So we'll take an example of, say, an elderly male who has a complaint of a UTI. Well, what's going to happen is typically UTI is an infection with E. coli. So we'll use that as an example. So E. coli is going to be getting into the lower urinary tract. We'll say since this person is elderly, they're geriatric, and maybe we'll say that they're in a nursing home. So we could say maybe hospitalization. That's kind of soft, but I mean, not much different than being in the hospital, being in the nursing home. And we could say they also have a urinary catheter. So we got a medical device as well. So they get somehow, because of that, they're a high risk population, they get E. coli inside their lower urinary tract. Well, E. coli is going to hang out in here and it's going to start to colonize the urethra and the bladder, and it's going to get into the cells and multiply and multiply and multiply, and that's what it does. It's taking up home and residence without paying any rent. So what's going to happen is neutrophils, or white blood cells, are going to come in, and they're going to try and fight this infection off. But E. coli is pretty aggressive. So the neutrophils come to the area to fight, but bacteria invade them as well, and they're able to overcome them. And so it gets past this lower urinary tract, and it will start to move up into the kidneys. So now we're going to have a bunch of E. coli hanging out in our kidneys because we got past our first wave of soldiers. And this is going to cause an upper UTI. So our typical UTI that we think about is going to be in that lower tract. Now we're in the kidneys, so we have an upper UTI. Now, the problem with being up in the kidneys is that the kidneys are one of our body's great filters, and they have a lot of blood supply going through them. So what's going to end up happening is the E. coli will get through some tissues and eventually make its way into the renal vein. And once it's in the renal vein, it can spread throughout the entire body, causing septic shock. So once in the bloodstream, again, the bacteria continue to come in contact with white blood cells who release cytokines and other pro-inflammatory mediators and ask for more white blood cell recruitment. So we're in here, we're in the bloodstream. Our E. coli here is coming in contact with these white blood cells. They're doing their job. They're calling for help, releasing cytokines. But as we had said before in our inflammation piece, we had our battlefield outside the blood vessel, right? It was in that interstitial space. And because of that, we were able to move all of our troops to the interstitial space. But now our battle's not in here at all. It's in here, in our blood system. So since the infection is typically fought in the interstitial space, the white blood cells also release pro-inflammatory mediators causing vasodilation and vessel permeability. Because again, they think they're out of the blood vessel, but in fact they're in, and they're just doing what they're supposed to do, which is call for help and make it easier for help to get there. So this is going to cause systemic vasodilation and a decrease in vascular resistance, resulting in a drop in blood pressure and lowering tissue perfusion. Adding to the decreased perfusion is the vessel kind of leakiness, again, from the capillary permeability. So we're going to have systemic drop in BP because we're going to have systemic vasodilation and systemic leakiness. So the vessel permeability causes systemic swelling, putting fluid between the blood supply and the tissue. So not only is it we're having this loss in blood pressure because we're losing fluid from our vessels because of our vasodilation and capillary permeability, but we're also getting a buildup in fluid between our capillaries and our tissue cells. So as this increases, we're going to end up expanding the space between our capillaries and our tissue, which is going to make it harder for oxygen to get into our cells. So we're going to have a low blood pressure, which is going to, keep our fluids in our body from carrying our oxygen-rich red blood cells to our cells. But now we also expanded the distance between those capillaries and that tissue, causing more of a decrease in perfusion. So now oxygen must diffuse through the extra fluid to oxygenate the cells. And this is what will primarily cause the shock. All right? So we have shock. But along with this, the white blood cells have identified attackers and established a battlefield. But they still want to destroy the pathogen. But the battlefield now is inside our blood vessels and not in the interstitial space. The white blood cells release lytic enzymes to destroy the pathogen, but this happens everywhere, all over the body. So damage also happens to the blood vessels as well. So it's going to try and release chemicals to destroy this E. coli, but unfortunately, we're going to have some collateral damage and it's going to start destroying our blood vessels as well. So now we have this kind of thing going on where our white blood cells are releasing this lytic enzymes, destroying the pathogens, but also hurting our blood vessels and hurting our cells. And so our body is going to realize that our blood vessels are being hurt. So coagulation factors and platelets and fibrin are going to come in to help repair those damaged blood vessels that our white blood cells are accidentally hurting. But because there's systemic damage, clots begin to form all over the place, including in the bloodstream, and clots cannot keep up with the damage. So they're kind of working really hard, but there's just so much going on because it's all over the body. It's having a hard time keeping up, and they're trying to repair all over your body. So now we're in this kind of weird state of systemic coagulation in the blood vessels while simultaneously bleeding and coagulating in the interstitial space. And so if you kind of think of this kind of cycle of damage, repair, damage, repair, and now since our blood vessels are compromised, we're getting damage, repair in the interstitial space, and this is what's called disseminated intravascular coagulation, or DIC. And this is a problem.